Welcome to The Explainer. Today, we're going to pull back the curtain on one of modern medicine's most essential, yet, let's be honest, kind of mysterious procedures: general anesthesia. You know the drill, right? One moment you're counting backward from 10, and the next you're waking up in a recovery room. It feels just like a simple switch flipping from on to off, but the science behind that seamless transition is, well, it's an absolutely fascinating and complex process. Okay, so let's really get into this. And first, we need to understand what general anesthesia is actually trying to do. A lot of people think it's just a really deep sleep, but that's not even close to the whole story. In reality, it's this complex, multifaceted state. The goal is to hit 5 targets all at once. 1. You won't feel any pain. 2. You won't remember the procedure. 3. You'll be completely unconscious. 4. Your muscles will be relaxed so the surgeon can work. And 5. Critical reflexes are suppressed. It's all designed to keep you totally safe and perfectly still. Now, here's the crucial point. There is no single magic bullet drug that can safely and quickly achieve all 5 of those goals. It's like trying to find one tool that's a perfect hammer, screwdriver, and wrench all at the same time. It just doesn't exist. And that's why anesthesia is really a science of combination. So that brings us to the very first step in your journey: the personalized plan your anesthesiologist creates just for you. There is absolutely no one-size-fits-all approach here. Before any drugs are even in the picture, they become a bit of a detective, meticulously going over your unique physiology. They're going to look at your heart, because anesthetics can affect blood pressure. They'll check your lungs. A condition like asthma definitely changes the game plan. Your liver and kidney function, that tells them how you'll process the drugs. And even the medications you're currently taking can totally alter the entire plan. What's really fascinating is that the process often kicks off before you even get the main anesthetic. You'll likely get what's called a pre-anesthetic cocktail. This could have a benzodiazepine like midazolam to ease your anxiety, an opioid like fentanyl to get a head start on pain management, and maybe even an antiemetic to prevent you from feeling sick afterwards. Every single drug has a very specific job to do. All right, so the plan is set, the pre-meds are on board, and now the process officially begins. And this isn't just a single event, it's more like a journey that moves through 3 distinct and very carefully managed phases. So this journey starts with the first, and you could argue most critical step: induction. This is the moment you're probably most familiar with. Yep, the countdown. The main goal here is to get you from being awake and conscious to a state of surgical anesthesia as fast and as smoothly as humanly possible. That speed is super important because it lets us bypass a potentially dangerous phase of excitement that some of the older anesthetics used to cause. And there are basically 2 main roads to get there. For most adults, it's an IV drug like propofol. It's incredibly fast. We're talking unconsciousness in less than 30 seconds. But for kids who might be pretty scared of needles, a non-irritating gas like sevoflurane is often used for a much gentler induction with a mask. So once you're under, the next phase starts: maintenance. And this is not a passive thing. It's an active, minute-by-minute balancing act that your anesthesiologist is performing for the entire surgery. Think of this timeline as the journey of your central nervous system slowing down. The entire skill of the anesthesiologist is focused on getting you to stage 3. That's the sweet spot for surgery, and keeping you right there. They have to completely avoid stage 2, which is why induction is so quick, and they absolutely have to prevent you from slipping into stage 4, which is extremely dangerous. So how do they maintain that perfect depth with gases? Well, they use this really crucial concept called MAC, or median alveolar concentration. You can think of it as the dosage for an anesthetic gas. It's a standardized way to measure just how potent that gas is. And here's the tricky part: the relationship is inverse. A lower MAC value means the drug is actually more potent. So a super potent drug like halophane needs just a tiny concentration, only 0.75% to work. On the other hand, a less potent gas like nitrous oxide needs a concentration over 100%, which is exactly why it's usually used with other drugs. This data is what allows your anesthesiologist to fine-tune that cocktail second by second. Okay, the last stitch is in place, surgery is over, and now we enter the final phase: your reawakening. And this is definitely not as simple as just flipping a switch back to on. In a nutshell, the way the anesthetic drugs leave your brain and body follows the exact same pathways as when they entered, just in the opposite direction. It all comes down to simple things like diffusion and redistribution. The anesthesiologist stops giving you the anesthetic, and your body immediately starts to clear it out. The real key to waking up is the redistribution of that drug out of your brain. And your care team is going to be watching you like a hawk in the recovery room, making sure your reflexes and vital signs, especially your ability to breathe on your own, are fully back online. So when you really think about it, from that custom drug cocktail made just for your body to the constant moment-by-moment adjustments needed to keep you in that perfect surgical state, general anesthesia is truly one of the most incredible, personalized procedures in all of medicine. And the amazing thing is, it just keeps evolving and getting safer every single day.